infections and lower respiratory tract infections. Upper respiratory tract infections are croup and epiglottitis. Lower respiratory tract infections are acute bronchiolitis and pneumonia, and this is in children. Laryngeal infections. First coming to croup, also known as acute laryngotracheobronchitis. Age 6 months to 5 years. Peak age is 2 years. Etiology, it's due to a viral infection called parainfluenza viral, which is most common. There is type 1, type 2, type 3. Type 1 is most common and intermediate severity. Type 2 is mildest of the disease, and type 3 is most severe disease. Clinical features: running nose, cough, upper respiratory tract infection. Symptoms: in 2 to 3 days, you have severe cough, barking, seal like brassy cough, inflammatory narrowing of larynx, stridor, trachea, and bronchi, wheeze. Child appears well despite symptoms unless it's severe. Severity classification. So it is divided into mild, moderate, and severe. When the infection of croup is severe, the baby will have stridor at rest, they will have severe respiratory distress, and their SpO2 will be less than 92%. While at moderate, they will have stridor at rest, respiratory distress will be present, but SpO2 will be normal. And everything will be normal on mild infections, only you will find there is stridor on exertion. In X-ray finding, you will see there is subglotted narrowed air column, which is a steeple or inverted V sign. Management. It is a self-limiting disease, and based on severity you can treat it. Mild group, you have to give oral dexamethasone, decreased inflammation. Moderate to severe, you give dexamethasone, O2 inhalation, and nebulize with racemic epinephrine. Decrease edema in precapillary arterioles. 1:1 DNL as isomers, racemic mesh, epinephrine. Acute epiglottitis. Age 3 to 6 years. Etiology bacterial. Acute epiglottitis is bacterial. Haemophilus influenza type B is the most common cause in India. Streptococcus pyogenes and Streptococcus pneumoniae. Here you can see the child is in tripod posture, leaning forward, opens up the airways. Clinical features: severe airway inflammation is a medical emergency, increased risk of obstruction. It's a sick looking child with high grade fever, stridor due to inflammation of supraglottic area. 3Ds of epiglottitis is dysphagia, they cannot eat, drooling of saliva because difficult to swallow, dyspnea, respiratory distress. Low grade fever is seen in viral infections. Low grade fever is seen in viral infections. X-ray finding, you see thumb sign, soft tissue shadow of swollen epiglottis. 2 laryngoscopy findings: inflamed cherry red epiglottis, not done routinely. Stimulation by laryngoscope, you have laryngospasm, which predisposes to respiratory arrest. Management. Secure airway is the priority. Intubation, if not possible, then tracheostomy. IV antibiotics, you give third generation cephalosporins because it is a bacterial infection. Hemoinfluenza type B. IV antibiotics, what you give? Third generation cephalosporin, which is IV ceftriaxone and IV cefotaxime. The third generation cephalosporins that you give in acute epiglottitis is IV ceftriaxone or IV cefotaxime. Acute bronchiolitis, lower airway infection. Incidence, it increases during winter, age less than 2 years, and the peak is between 3 to 6 months. Etiology is respiratory syncytial virus. Type A is more severe than type B. RSV can cause upper respiratory infections and lower respiratory infections as well. There is a vaccine of immunoglobulin against RSV which can be given to the children. Pathogenesis, inflammation of bronchioles, edema and increased mucus production, airway obstruction, increased narrowing of airway during expiration, air trapping and lung fills. Inflammation of bronchioles, edema and increased mucus production, airway obstruction, increased narrowing of airway during expiration, air trapping and lung fills. Clinical findings: due to air trapping, there is an increase in anterior posterior diameter and hyperresonance on percussion. Due to narrowing of bronchioles, you have wheezing. Investigation X-ray findings: peribronchial coughing due to inflammatory exudates. What do you see? You would see peribronchial coughing due to inflammatory exudates in inflammatory acute bronchiolitis. Bilateral hyperinflation, and there is also bilateral hyperinflation. Nasopharyngeal swab, you do PCR for respiratory syncytial virus. Management, usually self-limiting, 3 to 7 days. Supportive management: moist O2 inhalation, goal SpO2 more than 92%, fluid oral or IV. Antivirals is not routinely used. Preventions: for at-risk infants, you give palivizumab, monoclonal antibody against RSV proteins. What is the antibody that is used? Palivizumab. That is the antibody. Uh, in Canada, there is another kind of vaccine, which and the antibody and the antibody is called, just one second, nirsevimab injection in Beyfortus. So that is the vaccines given to babies, and for big adults they give RXV. But here they are saying that for prevention you give monoclonal antibodies. It's not a vaccine, it's palivizumab. Nirsevimab is the vaccine. Nirsevimab. Antivirals are not routinely used here. Only supportive management, self-limiting disease. Used in chronic lung disease. Antivirals can be used in chronic lung disease, congenital heart defects, at-risk infants, and drug which is used is inhaled ribavirin by nebulization. Pneumonia in children. Infection of lung tissue parenchyma, leading cause of under 5 mortality. Etiology: bacterial is more common than viral. Bacterial, you have your Streptococcus pneumoniae, which is overall most common. E. coli and Strep P streptococci. Most common in neonates is E. coli and group P streptococci, and which is more than viral, which is respiratory syncytial virus, which is most common. Etiological diagnosis is not always feasible. X-rays findings are more reliable. X-ray findings are more reliable. Etiological diagnosis is not always feasible. Clinical features: you have your fever, productive wet cough, may not be expectorated due to swallowing, tachypnea, cramps on auscultation. Community management guidelines. Guidelines given by Integrated Management of Neonatal and Childhood Illness. Management of child with pneumonia in a peripheral health setting at community level. Categories: features and management. No pneumonia. Pneumonia and severe pneumonia, also known as very severe disease. So color coded: no pneumonia green, pneumonia white, very severe pneumonia pink. No pneumonia, you will have fever, cough and cold. At home, paracetamol, that's it. Pneumonia, fever, cough, cold, fast breathing and chest indrawing, SpO2 normal. At home, paracetamol for or and oral amoxicillin for 5 days. If wheeze is present, salbutamol for 5 days. If cough is more than 2 weeks, evaluate for tuberculosis. So if there is pneumonia, that is cough, cold, fever, fast breathing, chest indrawing, normal SpO2, then you give at home paracetamol plus amoxicillin for 5 days, salbutamol for 5 days, more than 2 weeks cough, evaluate for 5 tuberculosis. Severe pneumonia, SpO2 less than 90% on room air. More than one danger signs. What is the danger sign? Lethargy, not feeding, convulsion, cyanosis. Urgent referral to tertiary care hospital. Also, first dose IV antibiotic can be given. Ampicillin and gentamicin. Which antibiotic to give? Ampicillin plus gentamicin in very severe pneumonia. You will have dropping SpO2 less than 90% and one of the danger signs like lethargy, not feeding, convulsion, cyanosis. Fast breathing criteria. Where can you say that the child is breathing fast? So depends on the age. When they are more than 1 year, more than 40 is the fast breathing heart rate. Sorry, respiratory rate. When they are more than 1 year, then more than 40. When they are less than 2 months, then more than 60. When they are less than 2 months, then more than 60. When they are 1 year, more than 40. Less than 2 months, more than 60, and between 2 to 12 months, more than 50. Pneumococcal pneumonia. A mode of transport is droplet. Season of increased incidence is winter. Features lobar consolidation on chest x-ray like it's shown here. Clinical findings: decreased air entry, cramps, sputum is if expectorated is rusty, bronchial sounds, dull and impaired note on percussion, decreased air entry, cramps, sputum if expectorate is rusty, bronchial sounds, dull, impaired note on percussion. Treatment: penicillin G 50,000 international unit per kg per day IV for 5 to 7 days. If not available, third generation cephalosporins, IV ceftriaxone or IV cefotaxime 50,000 international unit per kg per day IV. Staph pneumonia. Staphylococcal pneumonia. Bacteria. Staphylococcal aureus causes staphylococcal pneumonia. Staphylococcal etiology seen in spread from different focus of infection like pyoderma in the skin, secondary to viral infections like measles, influenza, etc. Cystic fibrosis, recurrent pneumonia. X-ray finding, you see pneumatocyst, air-filled cystic spaces, which is pathognomic of staphylococcal pneumonia. So there are air-filled cystic spaces which rupture and form pneumothorax. Bilateral patchy consolidation with pus. Bilateral patchy consolidation with pus. Empyema. If seen in child less than 2-year-old, most common it is a staphylococcal etiology. And there is purulent pericarditis. So pneumococcal is pathognomic, and empyema, if it's seen within less than 2 years baby, then most common etiology is staphylococcal. You will see patchy consolidation with pus for empyema. Treatment: antibiotics, amoxiclav, amoxicillin and clavulanic acid, or ceftriaxone plus cloxacillin. Suspected MRSA plus vancomycin for 7 to 10 days. So which antibiotics do you give in staphylococcal pneumonia? Amoxiclav, amoxicillin and clavulanic acid, or you can give ceftriaxone plus cloxacillin. If you suspect multi-drug resistant staphylococcus, then you give vancomycin. Primary typical atypical pneumonia. Organism most common is mycoplasma. Age is more than 5 years and it is rarely seen in less than 5 years of age. Features: low grade fever, cough, scattered cramps, hemolysis may be seen. Investigation: X-ray finding more significant than clinical findings. Cold agglutination test positive. The cold agglutination test is positive. IgM against RBC is hemolysis. Treatment: macrolides antibiotics oral. Azithromycin plus erythromycin, which is given 7 to 10 days. Macrolide antibiotics is given when the infection is due to mycoplasma for 7 to 10 days, which is azithromycin and erythromycin. Here is your interstitial pneumonia x-rays. Patchy cramps, low grade fever, cough, hemolysis. Cold agglutination test is positive. IgM is produced against RBC, so there is hemolysis. In the next video, we'll see about cystic fibrosis.